अच्छा नहीं नहीं we'll test it first. We'll test it first. Oh, it comes. Hello. దానికి ఆల్రెడీ వైఫై కనెక్ట్ చేశారు దానికి కూడా నేను ఇలా ఉంది మరి పరిస్థితి అయితే వర్క్ చేస్తుంది మరి అంత స్లో ఉంటే ఎట్లా మరి మన అయిన తర్వాత లేట్ వస్తుంది అఫ్కోర్స్ స్లో ఉంది ఎప్పుడు ఫాస్ట్ వస్తుంది తెలియదు ఎప్పుడు స్లో వస్తుంది తెలియదు కానీ ఇది ఇలా ఉంచు డిస్టర్బ్ చేయొద్దు अपना don't let that one to be disturbed. Okay. Yes. Once Asif sir comes, yes. This is mine. Yes. Okay. Once I will call. ఇప్పుడు కొంచెం బెటర్ ఉంది క్వాలిటీ కూడా బెటర్ ठीक है yes समझिए yes once Asif sir comes put it here నాకు ఫోన్ వస్తే నేను ఆఫ్ చేపిస్తాను నాకు ఫోన్ వస్తే నేను ఆఫ్ we have to take permission. Not this is not my company. This is the job I'm doing. Just like yes, you understood, right? Understood, sir. If I get a call and stop, it's simple as that. Following the process, sir. We need to follow the process. I know, sir. It will be like argument itself. This is going to be never ending argument. Simple, sir. Simple, sir. Right? You understand that I'm also doing my job. If someone says to don't do this, understand that who has put the link on what basis? I don't know. This is Moatis program, sir. Yes. Okay. Unless otherwise we agree, then let's go see that. That's what happened. On है क्या?
Honest.
हाँ, ऑफ कर लो. Once sir comes,
कॉलर में लगाना राइट कुछ बोलना चाह रहे आप चलो स्टार्ट या आ जाइए या यू कैन डू स्टार्ट इंट्रोडक्शन देन स्टार्ट
So thank you, Dr. Bruce, for the call. Thank you for taking out your time and attending this hearing. Today, this hearing is sponsored by ARNI, which is the for certification benefits. So today we have Dr. Asif sir, Senior Principal Technologist, working with the Accreditation Board. Is this discussion on API learning and how accreditation. So just requesting Asif sir to take care. Yes, thank you.
Okay, thank you very much for introduction and giving this opportunity to talk on heart failure reduce EF with LVEF improvement post treatment with ARNI. We all know it's a very well established fact that for heart failure over the decades the treatment has been changing. So over the span of 3 to 4 decades, we had beta blockers, we have ACE inhibitors, but somehow the few medications were missing in the management of heart failure. But this medication, ARNI, when it was introduced, it completely changed the management of heart failure. So just to make you understand how it has changed the management of heart failure, I can say 6 years back, I had a patient of heart failure. Her EF was 20% and she was advised on heart transplant. So they had affordability issues. So they came to me where the heart transplant was advised. I suggested this new molecule is there, let us start it. Let us see the response. Within 6 months of starting this medication, her EF from 20, it became 50%. So 55 we consider as a normal and her heart transplant was deferred, or we can say the heart transplant necessity or indication itself is ruled out because her EF improved significantly. So let us see similarly a case-based histories. A 54-year-old gentleman, a software engineer with a clinical history, complaints of breathlessness, and he has difficulty in climbing upstairs. So when for detailed investigations was done, it was found that his EF was 38%. Probe was slightly elevated and he is slightly overweight also. So patient was initiated with sacubitril valsartan combination along with beta blockers and MRS. So on regular follow-up, after 3 months, his EF from 38 improved to 43%. So what is this EF? Why it is so important for a cardiologist? In fact, not only cardiologist, for any field, if EF is good and any surgical field, they can do any surgeries without any issues. But when the EF is low, the ejection fraction, what we say, the normal ejection fraction is above 55. So there's nothing called 100% ejection fraction. It will be somewhere around 55 to 70 normally. Anything less than 55 is slight worrisome. Anything less than 40 is major concern, and any EF less than 30%, it is a grave concern where the patient can have death anytime. So EF less than 30%, these patients have regular hospitalizations and they can't do the normal quality of life. So it's very important that their EF should be always in the normal range or above 55, or those who had a massive MI or those who had any cardiac issues above 40 also we say that their quality of life at least it is not hampered. So this patient had an EF of 38. Once the ARNI beta blockers, all the guideline directed medical therapy was started, his BP, I mean the EF increased to 43%. So Do you think the guideline directed medical therapy should be changed, discontinued as his EF has improved and he is stable? So that is the next question mark. Many patients comes to us, now I am fine, my EF is normal or it has improved drastically, I am very comfortable, I don't feel breathless. So do you suggest me to continue the medication or do you want me to stop the medication? Well, the answer is you have to continue the medication despite being a normal, because we have seen many patients where once they discontinue the guideline directed medical therapy, again they go back to the severe dysfunction or moderate LV dysfunction. So patients of heart failure with reduced ejection fraction, they are more susceptible to get hospitalizations again and again. The more recurrent the hospitalization, the chances of death or mortality increases significantly. And we know that the lesser the EF, the higher the mortality. Okay, the EF goes down and down, the mortality graph increases significantly. Less than 30, it has got very high mortality, and 30 to 40, you can say the moderate risk for mortality. So there's something called what is called clinically stable. A heart failure patient, once is clinically stable, as a clinician, we also feel now the patient is fine, and the patient himself feel that I'm perfectly fine. Why should I take the medication now? And the very high chances that they can discontinue the medications. So that's basically a clinical stable is a misnomer, because the disease pathophysiology or the pathology is going on. It is not going to get completely normal until unless if the patient stop medication, everything can become reverse and he can go back again to the stage where he required hospitalization. So reduced EF is a progressive disorder whereby the cardiac structure, function and continue to deteriorate very regularly. If they don't take medication, then again the deterioration starts very faster. So the myth is the clinical stability, but the reality is that there is underlying structure and molecular abnormalities drive disease progression, which is silent and life-threatening. NHA class 2 heart failure patients are often perceived as a low risk or clinically stable patients. Again, we have to understand here that these are the ticking time bombs that anytime they can blast, means they can land up in suddenly from 2 to 4, that no time, and they require hospitalization. So that is very important that we understand, and they monitor continuously for the medications so that they don't stop and follow the regular advice of a cardiologist or a physician. So as I told, the NHA class 2, the risk of mortality also increases, because in no time they progress faster and land up in grade 4 or NHA class 4 SOB. So lack of many of our patients, despite our efforts, despite our counseling, we recommend them to follow the guideline directed medical therapy for heart failure patients, but very few patients adhere to the medications because of multiple reasons. It can be a financial issues or an ignorance or the lack of knowledge, or you can say like they themselves, they don't want to take medication thinking that they're perfectly fine and normal. So the lack of guideline directed medical therapy, it was found to associate with the higher risk of mortality in Indian heart failure patients. So whenever the guideline directed medical therapy is not is stopped or discontinued, then there is a chances that the patient can land up in heart failure in decompensated state, where you need to again run to the hospital in emergency department for stabilization. Then again you need to upgrade titrate the target doses, then introduce the newer therapies and evidence-based approaches to comorbidities. So guideline directed medical therapy is the foundation of heart failure care and is the highest expected benefit should be prioritized. So the question is now, but are we implementing the optimal guideline directed medical therapy in real life to manage the heart failure? So that is the thing. And I see many of the patients, heart failure patients, even managed by the physicians. So there is some medications which has to be given is been missed. So it is always better that experts manage the heart failure patients, because we have the pillars of heart failure management: ARNI, beta blockers, then we have MRA, now SGLT2 inhibitors has been added, one of the major pillar for the management of the heart failure. Then of course the diuretics comes the initial state, then diuretics later on can be discontinued. But apart from that, the iron therapy is one of the foundation treatment for the heart failure patients, which is very much under treated in heart failure patients. Again, the another question is the prescription of all these guideline directed medical therapy, which I told: the beta blockers, ARNI, MRA, and iron therapy if required, diuretic therapy, okay, then SGLT2 inhibitors. Apart from that, is the doses is sufficient or not? That is also a big thing. So once you prescribe, because the titration of doses is very important. Initially, whenever the patient is fluid overload, we try to give diuretics more so that make the patient completely dry. Once he is dry, you try to stop the diuretics completely, or a minimal lower dose of diuretics is sufficient. Other scenario is that the beta blockers, ARNI, that has to be upgraded. So that is often missed. Once you start with the fixed dose or the low dose, slightly increase until he tolerates. The maximum the dose, the maximum the benefit you get. Same thing with the ARNI, same thing with the ARBs or AC inhibitors, with the beta blockers or MRS. So this has to be kept in mind. So again, whenever you start the guideline directed medical therapy, so this is the chart where you can see the medications which I told: dapagliflozin, ARNI, ACE inhibitors, ARBs, MRS, and beta blockers. But many patients, the discontinuation is very, very high. Out of 4 patients, 1 patient, they discontinue any of these medications within 12 months. So this is a major concern, because you're not giving that benefit to the patient, and this indirectly reflect on the mortality, the recurrent admissions, and the sudden death. So discontinuation, it increases the risk of mortality, nearly 35% risk increase in the risk of mortality for patient discontinuing the guideline directed medical therapy. First of all, which medications to be given? That has to be given all 5. And second, the doses properly should be adjusted. So if this is not done, then the risk of mortality also increases significantly. Means to say, out of 3 patients, 1 patient is expected to die within 6 months. And the hospitalization, that is also, these patients, most of the middle class or lower middle class, they have financial burdens, but unfortunately because of this medication they think it's cost is an issue, they stop the medication, but the hospitalization itself will drain out their 2 years of what you can say the medication cost. So that is also a major concern. So in a nutshell, initiation and continuation of guideline directed medical therapy keeps heart failure with reduced EF patients alive and live longer. So this you have to understand. If this is not followed, the hospitalization chances will increase, mortality increase. If it is followed properly, then the heart failure hospitalization significantly reduces. To my personal experience, you can say that a lot of cardiac heart failure patients we treat, almost 30%, 30 to 40% of heart failure patients we treat. So usually some patients used to get recurrent admissions. So when we take detailed history, counsel them why it is happening like that, a few things: the discontinuation of medications or inappropriate doses. So few patients, when we counsel them, we started properly and kept on the adequate doses. The hospitalization rate from past, I think 3 years, 0 admissions, even in the year of 25-26%. And I have many patients, those who are adhering to the medications properly, they have a 0 admission rate for past 3 years, which it used to be every 2 months initially. It is now become a 0 for the past 3 years, irrespective of the year of 25%, 29%, 30%, 35%. And it is only for those patients who are sincerely adhering to the medications. But those who are not adhering, yes, we are seeing them in OPD regularly, the slight heart failure, so we are increasing the doses and sending, and sometimes they come to the emergency with pulmonary edema requiring intubation and all, or some patients don't turn up due to a sudden death. So with the above evidence, it is very clear that we should be continuing the ARNI. So the treatment of reduced EF recommend the patients to improve the EF, and the patients of heart failure, even if symptoms are well controlled and stable, remember that well controlled, stable, the medications has to be continued, and sometimes it is to be continued lifelong. And ARNI stands the first line therapy instead of ACE inhibitors or ARBs. Now it is a well established fact, and it is a major cornerstone treatment for the heart failure to reduce EF. Not only reduce EF, it has shown a benefit even in the preserved EF patients also. So impact of discontinuing the ARNI in heart failure with reduced EF, which I told already. Okay, the EF will drop significantly, say from at least some 8 to 10% fall in EF is seen. Then again, the end-diastolic volumes will all returns to the baseline. So once the EF falls, indirectly it reflects on the mortality. And again, is it essential to select a right ARNI? So that is also one of the question. Now we have a lot of non-innovative drugs, innovative drugs available in the market. So again, it has to be very careful and choosy. Selecting a brand also, it makes a difference. When if you go for the generic brands, then the chances of benefit, what we are trying to give, may not be complete. So again, the Novartis, which is developed, now the patent is off patent recently, but before that it was basically a Novartis, which is the innovator brand which we used to use regularly. Well, that benefit we may miss if the generic brand is used, we can say that. Okay, because it is supported by almost 8 years of positive clinical experience and 230 clinical trials. Okay, more than 3 lakh patients. Okay, and almost all over global trials, clinical trials, which supports, and 78 lakh patient years of exposure. Okay, so to conclude, even if the patient is stable in heart failure, they need to take medications, and the discontinuity of medications or inappropriate doses or any of the important medications of heart failure, if it is not given, the chances of hospitalization or mortality increases significantly. Okay, I think thank you very much. Any questions or doubts, I'll be happy to answer.
Once we started on ARNI, how do we monitor the contraindication for starting ARNI?
So usually there are 2 side effects were expected for ARNI. One is hypotension, other is hyperkalemia. Okay, even it is safe in CKD patients also. Up to stage 3, we can straight away start and we can monitor. Okay, if there is no hyperkalemia, I think we can continue. The only concern I have seen in few patients is hypotension. So once the hypotension is initially, what I do is the BP is lower side. Usually these heart failure patients, the BP is always on the lower side, 90 systolic or 100 systolic. We start with the 50 milligram half twice daily doses. So that is one way. But despite that, if they go in hypotension, we have to stop that medication for a few days, again restart it. That is the one way for monitoring. So only 2 concerns, that to hypotension and hyperkalemia. That is also hardly 3 to 4% out of 100. So it is well tolerated drug, but you need to see if suppose you are starting 50 milligram twice daily, after 2 weeks, if the patient BP is fine, is tolerating, you make it 100 twice daily. Then again after 2 weeks, you make it 100 twice daily. So go up to the 200 milligram of doses twice daily, so that to get a maximum clinical benefit. But only very few patients are able to tolerate the higher doses. But since the EF is low and the BP is low, only few most of the patients are at the lower doses. We can say that. And those who are in the shock, obviously, should not start. And those who are on advanced stage of CKD and all, I think you should not start this medication. And hyperkalemia, those patients also, you should be careful.
When can we start the patients of the acute heart failure? Can we start before discharge, or should we?
No, I think straight away we can start during admission itself. Yeah, right from the admission itself, we can straight away start. So the guideline, there are a lot of trials to support that. Straight away we can start it. There is no this thing until analysis BP is fine. We can start straight away. We should not be in shock. That's all.
Is it good for SGLT2 inhibitor
SGLT inhibitors usually we start before discharge.
They also can be started
Before discharge, yes. The fourth day, third day, fourth day, excellent results with SGLT2 inhibitors. It's more of now a cardiac molecule than diabetic molecule, I can say. We use left and right in all patients, irrespective of the diabetic status, because the results are excellent. And there is no shock with this medicine. There is one good thing. Yeah.
The patients who are already on maintenance hemodialysis, can we give to them?
I think yes, on hemodialysis patients we can give. They should not be, because our concern is hyperkalemia and all. I think that is taken care. I think we can give, and that will give the maximum benefit. Yeah. Okay. Thank you very much. Huh? Please, you want to speak anything? Yeah, please.
Thank you so much, Doctor, for presentation. I would like to ask you, sir, for taking us through these therapies and also taking us through the guideline-based approach towards heart failure management. So, thank you so much for all, and we can proceed to lunch.